Thanks so much, Bertha, and the team at Central and Eastern Sydney PHN for hosting tonight's webinar. As Bertha said, I'm Mark Gordon. I'm a registered nurse and I've specialised in respiratory education for the past 15 years. So my role as program manager at NAC is to look after the Asthma Best Practice program, where we provide education to primary care providers right around Australia. And I also work as a respiratory educator in a general practice here in Melbourne, where I work with the GPs to improve the health outcomes for all of our patients with asthma and COPD. So tonight is an overview of asthma management in 2020, and as Bertha said, I will stop about halfway through the presentation just to field any questions that you might have, and there'll be time for questions again at the end. So just to get started, oh, what's happening? I just can't seem to make the slide move forward. I'll just see if I can click it. Ah, sorry everyone. Technology. So tonight we're going to cover the Australian Asthma Handbook. We'll touch on, give a bit of a catch up on asthma pathophysiology and triggers, principles and management. We'll talk about written asthma action plans. We're going to talk about asthma and telehealth, and of course asthma and COVID-19 guidelines. So these are the formal learning objectives there, and I'm not going to read them out, but what I really want to say to you is that what's important to me is that you get the knowledge and information that you want tonight, and that's where your questions are just so important. You know, the presentation's put together from the NAC's point of view, but we want to make sure that you certainly get out of it what you want. So please do ask those questions as we go along. So I hope you're all really familiar with this website. This is the Australian Asthma Handbook. These are the guidelines for asthma treatment and management within Australia. They're free to everyone in primary care, or free to everyone really, and that's the website there, www.asthmahandbook.org.au. And all of the resources and all of the information in tonight's presentation is based on the Australian guidelines, of course. So if you're not familiar with that website, please can I encourage you to go there and have a good look at it. You're going to find everything you need in regards to asthma management on that site. And this is the National Asthma Council website. Gosh, my employers would be furious for me saying that. This is the National Asthma Council website, and it also has really important information for health professionals, but also some consumer resources on there, and then links to the Sensitive Choice website, which has further information for consumers. So please familiarise yourselves. You'll see there that there's a tab for the COVID-19 and asthma, and that's on actually both websites, so you can click directly on there and receive the latest guidelines in terms of asthma and COVID management. So just to set the scene and make sure we're all on the same frame line or timeline for asthma, asthma is a pretty common condition in Australia. So about 11% of our total population, which is quite high compared to some other countries. So that's about 2.7 million Australians that have asthma. There has been a decline in children and young adults that are diagnosed with asthma in the last 20 years or so, but stable in those over 35 years. It is a tricky condition, really. It's more common in boys than girls, and then after adolescence, it's more common in women, and we don't know why that is. People still die of asthma, so the most recent death statistics that we have are there, 389 people in 2018, and that number is reducing, which is excellent. But you know, we'd like to think that more of those deaths are certainly preventable. There's a lot of interesting aspects to asthma, and in the older age groups, those over 75 years, it's one of those conditions that's often underdiagnosed, and that's because those, you know, fairly simple symptoms of shortness of breath and perhaps a cough and perhaps a bit of a wheeze there as people get older, they just accept those symptoms as part of aging. And in fact, that's not right. And in my practices, I always say to everyone, shortness of breath is not normal, whatever age group you are. So we need to be investigating that. And the flip side of that is that reports from around the world and statistics from around the world would tell us that there's a number of people or percentage of people there that are diagnosed with asthma that may not actually have asthma, and they've perhaps been put onto these medications as part of management of a respiratory tract infection or some other thing, and then that diagnosis has never been revisited and they're actually still on those medications. So it's one of those conditions that we want to try and make sure we've got the diagnosis pretty right. So when we're talking about asthma, what are we actually talking about? It's a chronic lung condition which can be controlled, really quite simply controlled with medication in most people, but cannot be cured. And this is really important. As clinicians, we all understand this, but the public often think about their asthma when they're acutely unwell, so they'll certainly come and see a doctor when they've really got an acute flare-up of asthma, but at other times may not actually understand that the inflammatory process of the condition isn't actually gone away, hasn't actually gone away, and that's the underlying reason that we have ongoing preventer inhaled corticosteroid treatment usually. So it's really important to explain this to people. So in clinical practice, asthma is defined as the presence of both excessive variation in lung function, which we would be able to measure usually with spirometry, and variable respiratory symptoms. And we ascertain the variable respiratory symptoms either by doing physical examinations or, as I said, people will come in displaying these symptoms and we see them when they've got an acute flare-up, but we also need to see people when they're symptom-free so that we can perform that spirometry test and see what's going on. And this is where asthma is a really interesting condition. What does that mean to the person with asthma? We'd never say to these people, you know, you've got excessive variation in lung function. It means to them that they have good days and bad days. So they have symptoms at times and they don't have symptoms at other times. So we need to be helping them to understand that. I really like this diagram, and I'm just going to talk to you about this. Once again, clinically, I'm sure you understand that there's a multifaceted reason for the small airway obstruction that is so common in asthma, and this is inflammation of the lining of the small airways of the lungs and the bronchoconstriction of the smooth muscles in the walls of those airways and increased mucus production. So the airway on the left there is showing a normal airway, no asthma going on there, the lining is nice and thin. Air is travelling unobstructed through the airway down to the alveolar, and the muscles in the walls of the airway are nice and relaxed. We go over to the diagram on the right, and that's showing an airway where asthma has flared up. And you can see that there's changes to the lining of the airway, so there's inflammatory changes to that lining of the airway, thickened and narrowing the airway down. You can see the muscles in the walls of the airway have tightened up, also narrowing the airway down, and there's increased mucus in that airway, which also narrows the airway down. So when we think of that airway, the symptoms of asthma make a lot of sense. The cough, the wheeze, the shortness of breath, and the chest tightness. But I want to draw your attention specifically to the diagram in the middle. So this is what someone with asthma's airway may look like when they have no or very few symptoms. And this is where we need to think about how asthma is a chronic condition, so that you can see that the airway may not be back to 100% reversible, and that those airway changes may be occurring there for that person. So it's really important to explain this because, as I said, this underpins the reason that we treat people with ongoing preventer therapy. And so just keep that diagram in your mind as I talk through the presentation tonight. So those characteristics of asthma, as I've said, are so understandable when we think of that previous diagram. There's chronic inflammation of the lining of the small airways of the lungs, and that creates those symptoms. And the very common ones, as I said, are wheezing, shortness of breath, cough, and chest tightness. These symptoms can be widespread but variable. So if we're listening to the lungs, we may hear wheeze in a certain part of the lung, but not other parts of the lungs. But the symptoms can also reverse spontaneously or with treatment. And this is where some of the confusion for people can be around their diagnosis. So they understand that they experience the symptoms, but then they may actually resolve without any treatment, and this is where they can think that nothing's actually wrong and nothing's actually going on for them. We know that there's a lot of triggers for asthma, and the triggers vary for everyone, and if we can help people to identify their triggers, it can certainly help with managing their asthma. And generally we see that if you can identify triggers and sort out a way to reduce those triggers or manage those triggers, asthma control will be improved. And one of the biggest benefits of stable asthma control is, of course, that it helps to reduce the risk of that person having a severe flare-up. So that's a way to help improve that death statistic that I was talking about, is good overall asthma and trigger control. There's really common triggers to asthma, and some of these are quite unavoidable. So if exercise is a trigger for someone, then we need to be able to manage that. And true exercise-induced asthma is a condition in itself, but we don't want people avoiding exercise, laughter, any activity that may create the symptoms for them. So we don't want them to be avoiding that. But other things that are difficult or perhaps be more difficult to manage, and the common one is respiratory tract infections. And of course now coming into winter and flu season, this is when we need to be helping people to think about managing their respiratory tract infections, particularly if they've got asthma. Certain medications can trigger asthma in some people, and those are the common ones there, so we may be able to help with that. There's certainly comorbid medical conditions that also can trigger asthma, and allergic rhinitis is the biggest one, and I think that there's well known that there's a very common link between allergic rhinitis and those with allergic asthma. So the better we manage the allergic rhinitis, usually with intranasal corticosteroid sprays, then the better we can help control the asthma as well. But some of those other ones there, nasal polyps and reflux, for example. And then also recognising that stress or psychological changes can trigger asthma for some people, and if that's the case, then hopefully we can get them some help to manage those triggers as well. The avoidable triggers that we've got there are, the biggest one always is cigarette smoke. So we don't want anyone to smoke in the community, but we certainly don't want anyone with respiratory conditions to smoke. So at all times we would be discussing smoking cessation with people and helping them to avoid passive exposure to smoke as well, if that's a problem in their households. But other common allergens that can certainly trigger asthma, and pet allergies is quite common, house dust mite allergies, pollens we've talked about with the allergic rhinitis, and airborne molds. So I always encourage people, if they feel they have allergies, that we need to get those diagnosed correctly. So we would be getting them some allergy testing or doing a RAS test and making sure we identify those allergens as a trigger, and then we can help them to manage those. There's lots of other things that can trigger asthma in the environment though. So the cold air or rapid changes of temperature. So at this time of year in Melbourne in particular, it was 3 degrees here this morning, and then you go from your nice warm house out into that 3 degrees, and that temperature change can trigger asthma in some people. Strong perfumes, sprays, smoke, and that includes environmental smoke as well as the cigarette smoke, and thunderstorm asthma, as you would know, is a condition of southeastern Australia generally, and is related to the ryegrass pollen. Certain medications, as we talked about, and then Dietary triggers are not as common as the community would think, but if people do have concerns about dietary triggers, that's another area that's really important to have that diagnosed correctly. It's not a good idea for anyone to be on special diets unless there's a really good reason. So we want to try and help people to get that as a correct diagnosis. And as I said, the whole reason we're managing these triggers is to help improve their asthma control. So this chart is directly from the handbook talking about adult diagnosis of asthma. So we're basing our diagnosis on history, physical examination, diagnostic testing. We might do a treatment trial if we've got no other choices. It might be that a diary card could be helpful for people to understand when their symptoms are occurring and what those triggers might be. Asthma is one of these more complex conditions where we don't have a gold standard for that diagnosis, and this is where we need to integrate all of this information that we've got and just keep thinking and keep looking and keep investigating until we try and get that diagnosis correct. So when we're doing the history, of course, we're asking about those symptoms. What symptoms do people experience? When are they happening? What are their triggers? What relieves them, perhaps? History of allergy, so do they have allergic rhinitis? Do they have anything else that's going on? Our first degree history of asthma or allergies in the family, but no further back than that really. And have they ever tried any relievers? These medications are over the counter in Australia and a lot of people use them. So have they had a response? Because if they can clearly demonstrate that they have a response, then that's another piece of the puzzle in diagnosis. We ask about smoking history, all forms of smoking history, and whether they're still smoking, and we want to know that, of course, to think about other conditions such as COPD. I always ask people about previous respiratory hospitalisations. Have they ever been in hospital with anything to do with their lungs, and particularly with anything to do with asthma, because that's really important. And we can also take a good history about those comorbidities that we discussed in the previous slide. We, of course, do a physical examination, but remembering that it might be perfectly normal, particularly as we understand the symptoms are variable and they may not have any symptoms on the day they come in to see you, so they can be perfectly normal. But you may be able to hear a wheeze, or you may certainly see people with, you will, of course, see them if they're coming in for their acute symptoms at that time. But we're looking, we're listening, we're looking, and we're observing for signs of rhinitis as well. Our diagnostic testing, as I mentioned, there's no gold standard, but spirometry is the test we do. And spirometry assesses that airway function. So this is where we may be able to demonstrate that variability in function, and we would do that with a pre and post bronchodilator test, a spirometry test. Most children over about 6 and most adults can perform spirometry if they're coached and demonstrated to do the test correctly. Remembering, as I said, that the spirometry test may be perfectly normal if they're well controlled at the time of testing, or if they're already on asthma medication, that test may be reasonably normal. And just want to touch on peak flow, because peak flow is no substitute for spirometry. It doesn't give us nearly as much information as spirometry, of course, as you would all be aware. So at the current time with COVID-19, about spirometry was initially we were told not to be performing that, and those recommendations were eased early in May, and spirometry now can be performed on people that are afebrile and don't have any acute respiratory conditions at the time. But we are recommended to use an inline filter and be very aware of personal protective equipment and good infection control of the area where the test is performed. And I will talk about that later in the presentation as well. So I mentioned some further investigations that we might look for, and we want to identify any allergies, so skin prick testing for allergy or specific RAS test looking for allergens. But we can also do a lung function challenge test, provocation test, where we would induce the symptoms of asthma and then see if we can reverse that. And that's performed in lung function laboratories, and that's can be very diagnostic. Chest X-ray is not very helpful in terms of diagnosing asthma, but it certainly may be useful for differential diagnosis if there's something else that you're looking for there. So asthma is more likely if we can demonstrate that the symptoms are recurrent or seasonal, so people have got a history and a story that they can clearly demonstrate in terms of their asthma symptoms. And that can generally be that their symptoms are worse at night or in the early morning, that we can identify some triggers, as we've talked about, and that those symptoms are rapidly relieved with an inhaled bronchodilator or a SABA medication. Sometimes there's a history of asthma in childhood, and people can be well with no asthma symptoms for many years, and asthma can just recur at any point in time. Or of course, there's more mature onset asthma, so there's no childhood history. So, you know, that's another complex part of the diagnosis there. And then we've got the spirometry results, as I said. So if FEV1 is lower than predicted without any other explanation, or we can demonstrate reversibility on spirometry. And now we've got much more information about eosinophilic asthma. So if there's raised IgE levels without other explanations, we may be pointing there towards asthma as well. So I've talked a little bit about how complex asthma can be to diagnose, and we must always be thinking of alternative diagnoses as well. So just remembering those symptoms of chest tightness, wheeze, cough, and shortness of breath, and you know, there's a plethora of other conditions that may demonstrate those symptoms. Remembering also that I'd like to draw your attention that if cough is the predominant symptom and there's no other symptoms, then it's rarely asthma. So we just need to be very careful of that you know, that sort of non-specific cough, especially in children, or post-viral cough in adults as a single symptom. But there's lots of other things that cause those symptoms, as we talked about, and you know, cardiac failure comes to mind immediately for me, but other respiratory conditions, of course, bronchiectasis, largely underdiagnosed, COPD, very common condition in our community, reflux, as I said, these types of things, postnasal drip, thyroid problems, and just exercise-induced respiratory symptoms. There's, you know, quite commonly people have got this idea that they've got asthma because they feel they don't recover quickly enough after quite vigorous exercise, and sometimes that it's just normal huff and puff, and we have to, you know, try and have a talk and a think about that as well. Now I'm just going to pause there for a minute and check if there's been any questions, and I'll have a little drink of water while the girls tell me that.
Thank you, Mark. So far, there is one question, and if anyone would like to answer a question at this point, please type it at the column on your right. The question is, how safe is spirometry in our current COVID situation, and should we wear PPE or spirometry?
Okay, it's a good question, and certainly something that's been asked a lot in the current situation. So the information I'm going to talk about it, of course, but this information is available on the NAC website and also on the Asthma Handbook website about the current guidelines. So they're saying at the moment that spirometry is able to be performed as long as the person is afebrile and doesn't have a respiratory infectious condition at the moment. So you would be just asking the normal COVID questions and checking their temperature. Their recommendation is that every spirometer has an inline viral bacterial filter attached to it for the test. So if you haven't previously been using those filters, you need to source those and use them for spirometry. And then the infection control guidelines around that talk about having a separate area to be performing the test with minimal things in it, you know, everything that can be wiped, the surfaces can be wiped down and cleaned with disinfectant. You're observing the 1.5 metre rule, so you don't want the whole family in the room while the test is being performed, just the person and the operator in the room. In terms of PPE, the laboratories are using gowns and gloves and masks. In general practice, I would think if those are available, then yes, it would be very wise to use those as well. But please go to those websites that I've mentioned, and all of the links are there to the recommendations for performing spirometry and the cleaning guidelines as well.
Thank you, Mark. I have another 3 questions coming through. Any concern or tests should be done for adult onset asthma?
Sorry, Bertha, could you ask that again?
Any concern or tests should be done for adult onset asthma?
Any concerns on the tests?
Or test is said.
So I think what that might mean is that if you have any concerns about performing the test in your own practice, then certainly the recommendation is to refer to a respiratory lab where they will have the complete full PPE available. So if you don't have that equipment available in your own clinic, refer the patient on to a respiratory lab.
Thank you. The next question is, in children under 2 years of age, should we still call it bronchiolitis if they present with wheeze post-viral URTI?
So kids are quite tricky in that age group to diagnose, and in 2019 there was a review of pediatric asthma. So in children 0 to 12 months, the diagnosis of asthma should not be made except by a respiratory pediatric physician or a pediatrician. But from 1 year to 5 years of age, the diagnosis can be very tricky. So you would need to be really examining that child with the symptoms to try and make that diagnosis of asthma.
Thank you. And one last, before we move on, what age can we be confident in diagnosing asthma when can only do spirometry at 6 years?
Yeah, sure. So once again, I think that's referring back to that, you know, that tricky little group of the children 1 to 5 years. And I guess, as I've said, it's about demonstrating clear history, demonstrating some triggers, seeing and observing and recording those symptoms, and then perhaps demonstrating a response to an inhaled bronchodilator to try and make that diagnosis around asthma in those tricky kids. But don't forget, the steps are there on the asthma handbook, so you can go to the chart of diagnosing asthma in children, and it's got steps there to be guided, and if you need to, then you can refer on to a paediatrician or a paediatric respiratory physician.
One more just came through. Any test should be considered for someone with adult onset asthma?
Yes, so in adult onset asthma, we would definitely be doing spirometry, preferably before any therapy was commenced. So if someone were to present with the history and the story of the symptoms of asthma, or certainly presented with an acute flare-up of asthma, then we would need to treat and treat the acute flare-up, but then we would be performing spirometry to see if we could actually confirm that diagnosis with the pre and post bronchodilator spirometry test.
Thank you, Mark. Those are all questions so far.
Okay, so
session.
Thank you. Oh, well, it's fabulous to know that people are listening and have some questions. That's great. So I'll continue on with my slides now, and don't forget that there'll be another opportunity for questions at the end. All right, so just talking about the management principles of asthma. Remember, as I said, that asthma is a chronic condition, so it needs ongoing care, and it's not just about treating that acute attack. And of course, we do need to treat that, but we need to make sure, if possible, that we can get people back. And the guidelines recommend that people would be seen perhaps 2 to 3 days after an acute flare-up of asthma, but then again within 2 to 4 weeks for them to come back, so that you've got an opportunity to do all the things that I've just been talking about. Take a good history, do some diagnostic testing, explore some triggers, and talk about all of those things we've been discussing. And then we've got an opportunity also to put some self-management education into place, so that we can explain about the chronic inflammation and the bronchoconstriction, and then why the medications are different and how they work. And of course, our aim is that everyone with asthma has an asthma action plan, and we know in real life that doesn't happen, but we certainly want to try and get that into place. When we're talking about management principles, excuse me, we consider lifestyle issues, medical management, and managing their comorbidities. And that little brochure there is a patient-centred brochure produced by National Asthma Council. So that's a good one that's available free on the website for you to give to your patients once they've been diagnosed. Excuse me. So talking about lifestyle issues and the types of things that we look into, as I mentioned, smoking cessation always comes at the top when we're talking to anyone with respiratory conditions. So we would swing into action if people are still smoking, and put all of those options in place to help them stop smoking, and eliminating passive exposure to cigarette smoke as well. We identify the triggers, as I've talked about, and put in place some avoidance strategies or management strategies. We talk about healthy weight and healthy exercise regimes, and that's the same for everybody with chronic disease, but really important for those with asthma that we keep them moving and keep them well. And we talk about stress management if that's part of their asthma as well. So pretty common and general lifestyle issues for anyone with any chronic conditions. Nothing's too different there. When we talk about medical management for those with asthma, then our goals are to try and engage that person in self-management, and we talk about that a lot, but we don't always do it that well. And as I've explained about this, that because the symptoms are variable and because the triggers are variable, it really is down to an individual management plan. So we really want to be engaging that person so they understand what medication to use when. We're trying to optimise our asthma control, and we always talk about that, and that means that we've reduced the risks for those people of having a severe flare-up if we've got good asthma control, and we would try and do that with the lowest dose of preventer medication necessary. So we don't want people on high doses, and we don't want to be using complex medications unless we need to. And that's twofold, because we get good asthma control with a low dose of medication that will minimise the adverse effects of the treatment. It minimises the risks of flare-up, as I've talked about, and minimises that loss of longer-term lung function. And it helps people to have an improved quality of life, which is really important, because people can be quite scared about asthma, and they can be really worried about having acute asthma and worrying about that affecting them. So the medication regime is determined by the pattern and severity of symptoms, so how frequent those symptoms are and how severe those symptoms are affecting people. That ascertains our asthma control. So this is a preview of the new stepwise management for those with asthma, and this was just released a week or two ago. The full update to the guidelines will be released in mid-July. So those of you that were familiar with this stepwise management will see that it's changed just a little bit, and the biggest change there is at step 2. So we've got very few patients at step 1 that are managed with bronchodilator alone. So we would only consider managing people with bronchodilator alone if their symptoms occur less than twice a month and they don't have any risk factors for flare-up. So that's not very many people. The majority of people that we're managing in primary care are those at step 2 level, and they would be managed with regular maintenance inhaled corticosteroid with a SABA or a bronchodilator to use as reliever as per their action plan. Or now we have an option of the budesonide formoterol low dose to be used as needed. So that's the change that's just come in. And then step 3 is if people are poorly controlled at step 2, then may need to check up to step 3, where we'll be having them on regular daily inhaled corticosteroid and LABA, long-acting bronchodilator as a low dose, with their bronchodilator as reliever, or they can use the budesonide formoterol combination as maintenance and reliever therapy. And then beyond that, we go up to the higher doses, and if they're not well managed there, then we would refer on. So I'm sure you're all familiar that worldwide there's an over-reliance on bronchodilator medications. They're cheap, they're readily available to people. They're over the counter here in Australia, but they do not address airway inflammation. So the majority of our patients really need low dose preventive therapy, and that's what we would be encouraging. So the reason that we're encouraging them to be on the medications, of course, are that we want to reduce their risks of flare-up and we want to achieve good asthma control. And what I mean by asthma control is assessing their symptom pattern and severity over the previous 4 weeks. So we ask them those questions. How has your asthma been? How many times has asthma woken you up at night? How much reliever are you using? How much is asthma stopping you doing your normal activities? These types of questions will give us the guidance to symptom control. And we want to know that because we want to make an assessment of risk factors. So if people have got under-recognised symptoms or they don't understand that continuing to have these symptoms puts them at a greater risk of a flare-up, we would consider that would be poor control. So there it is there, daytime symptoms less than 2 days of the week, using their reliever less than 2 days of the week, excluding before exercise. They can do all of their normal activities without any symptoms, and asthma is not waking them up at night or first thing in the morning. There's lots of reasons for poor asthma control, and I'm sure you would be very familiar with these, but the most common one is actually that they're not using their medications correctly, or they're not using them as you've prescribed them, is the 2 things that I really see the most in my practices with people. And I think that comes back to understanding the condition. So as I said, they're willing and happy to use all that medication while they feel those symptoms, but then once they feel well, they go, wonder why I'm on this. No, I don't need it. I'll just use my reliever now, or I'll just use nothing because that's all gone away. So it's about educating them about the inflammatory process of asthma. Other than that, we may have the dose actually too low. So thinking about that stepwise management treatment plan that we've got, or something else is going on altogether. They're adhering well to their medication. They're using their preventive therapy as you've scripted it, and they're taking it correctly, they're using their device correctly, but something else is still triggering asthma for them. So that's when we look at other things, allergic rhinitis or exposure to chemicals, or they've continued to smoke. What people don't understand, that the changes of smoking to the airways, to the lining of that airway, means that they will need a higher dose to maintain good asthma control. The medication isn't absorbed the same way as those who don't smoke. This all relates back to their limited knowledge of asthma or understanding the condition. They may have no asthma plan, nobody may have explained to them about the importance of regular preventive therapy, or something else is going on altogether and it's not actually asthma that we're treating. So I just want to chat to you a minute about the opportunity of self-management for people, because we really need to make sure that we've got our good tools of explaining what asthma is. So that might be diagrams, or it might be airway models, or it might be anything that you've got that you know makes a lot of sense to people, and explaining the condition to them in a way that makes sense to them and is understandable to them depending on their level of health literacy. And that's a great opportunity then to bring in about a personalised written asthma action plan. And this is why it's so important to see people when they are well. So that asthma review appointment is really important. And it's an ongoing process. This can't happen in a single visit, and it certainly can't happen straight after an acute flare-up. So it's a good opportunity to check their device technique, so ask them to bring their medications and devices in and get them to show you how they use it, so that you can be confident that they're using those correctly and we're reducing or preventing any side effects. It's a great opportunity to talk about seasonal management if they do have seasonal allergies, talk about immunisations, flu vax, pneumonia vax, of course. All part of our normal chronic disease management and asthma management as well. So I think this slide always comes as a little bit of a slap on the face, because I work in respiratory education and the stats don't support the good work that I think I'm doing. 78% of us people in Australia with asthma believe they're well controlled, but the data would show us that if we did the asthma control scorecards, that only 13% of patients are actually well controlled. And alarmingly, 58% of patients use their reliever at least twice a day. So we know that that indicates poorly controlled asthma. So we don't want to just ask, how's your asthma going? Because everyone's going to say, oh yeah, fine, I'm doing really well. We need to ask these questions a little more carefully, like how many times have you used that reliever, or has your asthma woken you up? Those types of questions. I'm sure you're pretty familiar with that. In primary care, we can get ourselves a bit lost in the language. So we talk about asthma management plans, we talk about GP management plans. Patients may not know the difference, and we can get ourselves confused. So I like this diagram because it helps to explain what we mean about plans. So asthma is a chronic condition, as I said, and people are eligible for GP management plans to help us plan review visits and have an opportunity to talk to them when we're well and encourage them to be involved in their self-management. When their asthma is worse, then we of course have written asthma action plans. So that's a patient-centered document which is individually written for each person that helps them to understand when to change their medications and what to do about that. And then we have asthma first aid plans, which is the community type plan where anyone out there in the community can start treatment if symptoms are happening to somebody right in front of them. So asthma action plans, I hope you're doing them in your practice, and I hope that your statistics of asthma action plans are higher than the average country ones, because we don't do so well. We do well with kids because schools and childcare centres require them, but we don't do so well with adults. But the purpose of a written asthma action plan is to help people recognise worsening symptoms for themselves. So these can be individual, but these are the common ones, that asthma will wake them up at night, or that they'll get symptoms with exercise or exertion. They can recognise that by needing their reliever medication more often, of course, or if they are doing peak flow readings, then there's variability there or falling. So the plan talks to them about recognising their worsening asthma and then how to respond. So we need to write down what we want them to do, how to adjust their medication, when we want them to come and see you at the clinic and see their doctor, or if it's really rapid and severe changing in symptoms, then when to call an ambulance. And, you know, a lot of people in our community are quite reluctant to call an ambulance, but asthma is one of the conditions that we really need to discuss that with people and say to them that if they're feeling anxious and they feel their reliever medication isn't working, then it's safer to call an ambulance than to drive themselves to the hospital. So written asthma action plans need to be personalised to each individual patient. They need to be in a language that that person understands. So don't use any abbreviations. Make sure that they understand what it is that you want them to do. Needs to provide advice about modifying their treatment. So what do they take more reliever? What are they meant to do if they're feeling those symptoms? And as I said, talking to them about when to call an ambulance or when to seek medical advice. There's a lot of guidance in the handbook about writing asthma action plans, so I would encourage you to certainly go there and have a look at that if you've got any worries about writing a plan. These are just some of what the plans look like. So to me, it doesn't matter what a plan looks like. It's lovely if we've got opportunity to do a colour one, and many of the respiratory plans are in their traffic light colours of green for when you're well, and then orange, caution, changing in symptoms, changing in management, and then red, it's becoming urgent or an emergency situation. If you don't have opportunity for colour printing, of course, and plans are in all our medical software programs at the moment, then it's just about talking to people and documenting clearly for those same things, when they're well, when their symptoms change, and when it's an urgent situation. There's an action plan library on the National Asthma Council website where there's quite a suite of action plans that you can import and use in your medical software, or all medical software programs now come with asthma action plans in them. And there's some on other places like the Royal Children's Hospital, for example. And you may find plans in your own health pathways or in other places. There are some targeted asthma action plans, so there's some with pictures on them that can be quite helpful, or Symbicort Maintenance and Reliever Therapy has their own plan, and they are available on the NAC website or through the company AstraZeneca. So just touching on community first aid, because this is a question we get asked a lot, what's the difference between asthma action plans and community first aid? So those charts there are the first aid asthma charts that are on the website. But community first aid is what we would do if in an emergency, and this can be at school, at home, at sport, or wherever it might be, and it's generally known as the 4x4x4 protocol. So that's 4 separate puffs of short-acting reliever therapy, and the common one is Ventolin via a spacer, and that's 1 puff at a time, 4 breaths per puff into the spacer, wait 4 minutes. If symptoms haven't been relieved or are getting worse, then you repeat steps 1 to 3. And if you've done that twice, then you need to be dialing 000 and continue to administer the Ventolin until the ambulance arrives. So it's always worth just understanding community first aid and making sure that patients and families understand it. And I think the tragic thunderstorm asthma episode in Melbourne a few years ago really demonstrated the reasons why we need to treat community first aid for asthma. So I'm just going to talk to you a little bit about asthma and telehealth, because telehealth's come into its strides during COVID. It was available before that, but of course now it's really important, an important tool that we're able to use in our primary care settings to help us manage our patients at this point in time. So it's a good time, and asthma review is perhaps an appointment that you can do by telehealth. It's a good way to engage and keep in touch with those patients. So over the phone or video, you can assess asthma control, as I've talked about, by using an asthma score check questionnaire or asking those important questions and documenting that down. You can discuss about their written asthma action plan, see if they have one, see if they understand it, see if they've needed to use it. And you can talk to them about the supply and access of medication, because there's been some regulation put in place about accessing reliever now, where pharmacists are required to ask people if they have a diagnosis of asthma and are able to dispense one reliever therapy at the time. So this is a good opportunity for health professionals to be talking to patients about that. If it's a video telehealth appointment, then you may be able to get them to demonstrate their device technique. And if you can't do that over the phone, then perhaps that's a really good chance for you to suggest that they go to their pharmacy and have their device technique checked, because that's so important that they're using that correctly. For further information about the telehealth item numbers, please go to the MBS online website there for a fact sheet, and that's got all of that information for you. But it's just, I wanted to just highlight those points. And then just lastly, talking about asthma and COVID-19, as I said, it's in the handbook for your reference, or there's a link on the NAC website. But from an asthma point of view, it's important that everyone with asthma has a current asthma action plan, and that I've talked about performing spirometry so that we've put the right recommendations into place for performing spirometry during COVID. We want everyone with asthma to continue on their current asthma medications at the moment, including their inhaled corticosteroids, of course. Medically, they're saying to only use oral steroids for severe flare-ups as indicated. That's no different to any other time, really. But importantly, this is a time when we want to really avoid using nebulized therapy, and that's not a new guideline either. Nebulizers, we discourage home use of nebulizers always, and they're really reserved for acute settings now, but a well-fitting mask and spacer is preferred. So it may be an opportunity, if you know that some of your patients are still using their nebulizers at home and they really don't need to be, it may be a good opportunity now to discuss not using those, and you certainly would be trying to avoid using them in your clinics. It's a good chance to reinforce not sharing any medications or spaces, even between family members. So really encouraging everyone to have their own medication and their own spaces. And just talking to people about availability of medications and having their medications as per their plans. So that's the end of my presentation tonight. As I said, all of the resources that I've talked about are available through the handbook or through the National Asthma Council website there, and I'd really encourage you to access those. In non-COVID times, NAC would post charts and brochures and booklets out to you for free. Currently, we can't do that because we're all working from home. So currently, they're available for download from the websites. The how-to videos are on the websites for checking people's device technique or encouraging people to go there. If you want to join the NAC Health Professional Network, there's the links there, and the Twitter and Facebook. So can I just remind you to complete your evaluation when you get that link sent to you? That's really important for us here at NAC to make sure we're on the right track with our education and with our webinars. So I'll just see if there's any more questions, and thank you all for your attention tonight.
Thank you, Mark. There are very few questions actually, so we'll start with the first one. Can severe asthma cause a mixed obstructive and restrictive picture on spirometry, perhaps due to gas trapping?
Yes, long-term severe asthma can certainly cause some long-term changes to those airways, and we can certainly get what we call that more persistent obstructive picture when people have had asthma for a long time, or asthma that's been are perhaps less well treated or not diagnosed early, where people have tolerated those symptoms for a very long time and it's a later diagnosis and the disease has progressed a bit further. So there can be what we would call fixed or persistent obstructive changes on the spirometry, and that might be an opportunity then to investigate further. So there's quite a lot of talk about asthma and COPD crossover condition, where you've moved from what was a fully reversible airway condition to a more persistent obstructive condition with some features of COPD there. So yes, the answer is yes.
Thank you. We have about 5 minutes left, so we'll try to go through the questions, as obviously the topic is very popular. Asthma usually starts in childhood. For adult onset asthma, after confirming the asthma with spirometry, do we need any additional investigation such as CXR or CT lung scan to rule out other lung pathology?
Well, that's a clinical decision, I guess, of the person who's making the diagnosis. From my asthma educator point of view, I would accept if the diagnosis was clearly demonstrated on spirometry and you could clearly demonstrate airway reversibility, then you would have a diagnosis of asthma and you could commence treatment for asthma. But I guess in a situation where there were the other complexities there and you weren't quite sure, you may want to do further investigations. As I said, chest X-ray doesn't tell us anything about the small airways of the lungs, but it may exclude differential diagnosis if you were concerned about infection perhaps or something else. And CT of the chest, it's a more complex test, and I think once again, if you've got a clearly demonstrable spirometry result that indicates asthma, there wouldn't be much indication for CT. But I'm not a doctor, so please forgive me for answering that with a little bit less surety, but I think that is a clinical choice for the doctor.
Thank you. The next question is, should all patients be changed over to new guidelines, even if they are well controlled?
To the new guidelines. So I'm thinking that question means, should they be changed over to the budesonide formoterol combination? And once again, that's a prescriber decision, but no, step 2 says now that we're fortunate. We've got a choice in the way we manage people. So if people are well and are well managed on low-dose inhaled corticosteroid with their short-acting reliever as needed, as per their action plan, there's no need to change them over. But you've got a choice of treatment now. That's perhaps the way to understand that new guideline. There's a bit more choice there.
Thank you. Next question is, can you run through the changes with using Symbicort and as preventer and reliever protocol? I may have missed it. Sorry if somebody was running late, repeating yourself. So can you run through the changes with using Symbicort as preventer?
Okay, so just going back to that stepwise chart, I think that might be referring to. So as I said, the guidelines now says that very few patients are to be managed on short-acting reliever alone. And then the majority of the patients that we see in primary care, the recommendation is that they are on a low-dose preventive therapy. And now we've got a choice of what that might be. So it may be a low-dose inhaled corticosteroid and still use their short-acting reliever when they need it, or they can use the Symbicort, or there's other products, budesonide formoterol combination on an as-needed basis. So those are our two choices for the majority of people. If they're not well controlled on that, then they step up to step 3, and that would mean that they would have low-dose inhaled corticosteroid with a combination therapy, so a long-acting beta-2 agonist added in with short-acting reliever therapy as needed. And or they can have the budesonide formoterol Symbicort as their maintenance dose, so they're taking that perhaps twice a day, morning and night, and then using that same medication as reliever therapy. So
thank you.
If that's
yes,
still,
sorry.
If that's still confusing to the person that asked that question, please go to the Asthma Handbook website, and that chart is actually available on that website, and they can read all of that information on the chart.
Thank you. Another question is MDI and spacer is best. We know this, but after this, what is the order of efficacy of devices?
Okay, that's a good question. So there's many studies being done on device therapy, and they all deliver medication to the small airways of the lungs as long as a person can actually use them. So this is where it's really handy to have placebo devices available, where you can actually get people to demonstrate to you that they've got good inspiratory capacity and that they can actually use those devices. So all of the devices give good medication deposition into the small airways of the lungs as long as people can use them correctly. Where we go a bit wrong is not checking that. So some of the devices need to have quite steady hands, or maybe more difficult for people perhaps with arthritis of their hands. They may not be able to press an MDI or whatever it might be. So it's about matching the device to the capacity of the person. But certainly in an acute asthma episode, MDI and spacer gives by far the best deposition of medication in acute symptoms.
Thank you. We might just have another 2 questions before we finish for tonight. When do spirometry for patients, what position do you suggest for patients, as in sitting position or standing position?
Yes, once again, an excellent question, because people feel as though they can blow out harder if they're standing up. But we certainly recommend that everyone is seated for spirometry, and there's 2 reasons for that. So to perform the test, and please try it on yourself if you've never done so, is quite hard and can be quite exhausting for people, and also can people can feel a little bit faint or weak. So we want people sitting down. But the other reason is that the reference values that we check our results against were performed on people seated. So the test is recommended that you're sitting in a chair when you do it.
This will be the last question, but it's bundling a few questions on difference and use and how to use Symbicort and Seretide, if I pronounce it well, and where they can be used as a preventer and reliever.
So no, Seretide cannot be used as a maintenance and reliever therapy, and Symbicort can be. And the reason for that is that the long-acting beta-2 agonist in the 2 medications is quite different. So formoterol, which is in Symbicort, and the Duo-Resp Spiromax is a faster action long-acting reliever, so that works within 1 to 3 minutes. But that same medication, the long-acting beta-2 agonist that's in Seretide, has a slower onset, 20 to 30 minutes. So the Seretide cannot be used as a reliever therapy.
Fantastic, thank you. I believe there are only a couple of questions that we don't have time to ask, but we will email it to Mark, and the answers will be sent back to the participant who were asking
Sure.
those.
Yeah.
Thank you very much, Mark. Bertha?
Thank you, Lydia. And thank you very much, Marg, for tonight's presentation. It was very useful, and we did have a lot of questions from the audience, so we'll send those through to you, and if you can send us some answers back, we can then share it with the group. So again, thank you, and thank you to everyone for attending. You will receive an email with the evaluation link, so please ensure you complete the evaluations, and then we will send out the certificates, and we hope to see you online again soon. Thank you, and have a good night.
Thank you.
Thank you.